Hey guys, Corey Correa here. Welcome to Blue Talks, and I hope you enjoy this video.
Hi, thanks for having me here today. So here's my question, and I really need to know the answer to this. How many people in this room have someone in their life that's had problems with addiction? Yeah, see, pretty much everybody, right? It's a really common problem. I mean, it really touches everybody in a number of different ways. Some people have an addiction, some people have been a family member or a clinician. It touches a lot of us. So I want to introduce you to my patient, Bill. So Bill was a person who had been addicted to heroin. He'd been to 15 rehabs and he was still doing heroin. At this point in his life, he was living in a tent. And his mom came to me and said, I don't know what to do with my son. I need your help. I can't sleep at night because I am so worried that I'm going to get a phone call from the policeman and he's going to say my son's in jail, or worse, that he's dead. Way too familiar of a story. There's lots of smart clinicians. There's a lot of money. And the people that want to get off are really motivated. And with all that, you think we should be doing a great job, but no, we're getting a 20% success rate. You're like, if you're a clinician or you're a family member, that's really frustrating. So I actually went to a methadone clinic just to see how it worked, right? And I was talking to the clinicians and they were really caring about their patient and knew their story. They knew what they were doing. And I said, well, so what's your success rate? She goes, I don't know. We don't keep track. It's too demoralizing. I'm like, yeah. So it doesn't have to be this way, right? The problem isn't the clinicians or the person or the family. It's how we think about addiction. It's how we talk about it. It's how we define it. So the current model that I use as a doctor is the disease model. So the disease model says you have an incurable disease, you make poor choices, you have a personality disorder, some kind of psychiatric illness. And the best treatment for you at this time is to go to rehab, and you're going to be there for, 1 to 6 months. You put your life on hold, and someone's paying $10,000 to $60,000 for this experience. And if you're good, you get to graduate. But if you're not, then they kick you out. Like if you lapse, they kick you out, and you're back in your tent. If you graduate, then you go to sober living, and you're there for 3 4 months, and then you finally gradually work your back to normal society. But if you relapse, turns out there's no money back guarantees. And so then the process starts all over again. So this process, think about this, 8 out of 10 bills are back in a tent. Something's wrong here. Something has to change. So I read this book by a guy named Thomas Kuhn, and it's called The Structure of Scientific Revolution. And when I read it, I thought, man, I just like it's an epiphany to me, right? And I said to my friend, you got to read this book. And when he read it, he's like, Sprouse, like, were you on drugs or something? This book is dry. I'm like, wait, what? No. So when I went back and read, I was like, yeah, I must have been. It was like, okay, yeah. Turned out I put a lot of stuff into the book that wasn't actually there. But the point of the book is that science grows by steps. It grows by baby steps, little step, little step, little step. But every once in a while, there needs to be a revolution. And I think in the addiction world, it's time for a revolution. So the first thing I want to do is change the name, right? So when someone gets called an addict, that is not a good thing to hear. Like nobody wants to be called an addict. It's stigmatizing, it's hurtful. And so people fight that diagnosis. And the second thing is, as a doctor, what I hear is, okay, addiction has been stretched and strange. And so now it's called a biopsychosocial disorder. I'm like, what the heck is that? I don't even know what that means, right? What isn't? So I want to change the name to stress reducer lube. You're like, wait, what does that mean? All right, so here's the deal. So everybody here has stress, right? And we all have toolbox of stress reducers that we use, that we can pull out, right? So some people exercise, some people work, some people go on vacation, some people drink alcohol, some people do heroin. And guess what? They all work. Some are more powerful, some are more convenient, but the person gets to choose which one they're going to pick. So it turns out that a stress reducer is actually a treatment. And it's a treatment for stress. It's not a disease, it's a treatment. So the stress reducer can be a drug or it can be a behavior. But when it's successful, it gets repeated. And guess what? All this is normal so far. So when humans repeat something over and over and over again, the brain adapts and they make an anatomical connection. There's actually neurons that link up together, and it links up the stimulus, right, the trigger, to the behavior, to the drug. And so there's this, the trigger is off, the track gets used, and all of a sudden now you're doing your stress reducer. And we call that a habit. Guess what? So far, still normal. So here's where the problem starts. So when the stress reducer starts causing stress, okay, now we're in a stress reducer loop, right? The more stress, the more you do your reducer, the more stress, and now you're in this loop. So let's go back to Bill, and I'll give you an example how this works. So Bill's in his tent, and he's cold, and he's gone into withdrawal, so he's stressed out. So he goes out and finds his dealer and gets some heroin, and he feels better. Oh, but then it turns out it was a bad batch of heroin. So he starts overdosing. So now he ends up in the hospital with a huge bill. Oh, and he gets arrested. So his stress, he did a stress reducer heroin, but then it caused more stress. And so he's in this loop. And the key is that it's no longer a choice. It's not a choice because there's an anatomical track in his brain that says, when you do that, you go do that. So the skill that Bill needs to develop is not his ability to choose. What he needs to develop is his ability to inhibit. And it turns out that humans aren't real good at inhibition. We can inhibit for a while, but if you keep repeating the stimulus over and over and over again, eventually you kind of give in. So like at one point I was trying to lose some weight, right? So I'd go to a party and there'd be a dessert tray. And I'd walk by the dessert tray 10 times. But the 11th time, there was, damn, eating the dessert. And it turns out that 80% of us would have been eating the dessert, right? So inhibiting is really hard. We can do it, but it's hard. And this explains why relapse is so easy, because that anatomical track is in there. So another problem that stress-reduced loops pose is why we can't find something wrong, right? Scientists have been looking for a gene that's messed up, a personality disorder, a brain abnormality, something that we can use to predict who's going to be an addict before they become an addict, right? And we haven't been able to find anything. And here's the reason why. Because the process is normal. You can't find normal. Normal is normal, right? So when I told Bill, I said, Bill, you're normal. He looked at me like, what? I don't think so, right? He goes, I've been told I've been diseased and brain damaged and stupid. Yeah, I don't think so. He goes, wait. He goes, oh, wait, let me think about this. He goes, my sister has a problem. I go, what's that? She goes, well, when she gets stressed out, she goes shopping. And when she's gone shopping, she gets all these clothes, but now her closet's filled up. Her credit cards is maxed out. Her husband's giving a really hard time, which stresses her out. And guess what she does? She goes back and shops, right? I'm like, yes, that's exactly what I'm talking about. So his sister has a shopping stress reducer loop, okay? So if you use the stress reducer loop model, how does that change how we address and treat patients, right? So the first thing when a patient comes to me and I go, hey, you're normal. And they're like, what? That doesn't make any sense, right? But that's a very different thing than when you say to somebody, hey, you're diseased and brain damage, blah, blah, right? So when you tell someone they have a disease, they get defensive. They get angry. They don't want to come back. And in fact, they don't want to come at all, right? So the second thing I do is I tell them, you know what? You're really resourceful and intelligent. And again, they're like, what? Right? I'm like, no, think about it. You're having all these side effects to this loop that you're doing, and you're still able to do it. So for Bill, at the time, he wasn't in jail, and he was still alive. So yeah, whatever he was doing was still working, right? So the next piece then is to go, okay, so let's look, see if this is a stress reducer loop is a problem with what you're doing to reduce your stress. Where's your stress is coming from? So I go, hey, in your past, you have PTSD. In your present, you're like, whoa, you're living in a tent. That's got to be stress, right? And for his future, he was worried that he was going to die being addicted to heroin. So then I go, okay, so what other factors could be involved in what's going on here? And I go, oh, so Bill turned out had an anxiety disorder. So every stress that he had that should have been a 5, for him it was a 10. Then I had other patients who had ADD. And guess what ADD patients can't do very well? Inhibit, right? Then I go, okay, is there any other stress reducer? So I've had patients come in, and here's, like, you have to think about this now. So I had a patient that would lie to his grandmother that he wasn't doing heroin. So it turns out lying is a stress reducer. So by lying to his grandmother, he got to stay in her house. But here's the problem. When she found out he was lying, now not only did he get kicked out, but now he can't see his grandmother ever again. So his stress reducer just made things worse. So then how's that change the job of the clinician? So my job now becomes not figuring out how to fix your disease. It becomes, how do I find a way to have you have less stress? Because if you don't have stress, then you don't need the treatment. So I get my book. It's called Highway to Your Happy Place, a roadmap to less stress. And I show them to the patients. And I go, here, look, this is a better way for you to manage the stresses that you have. And then we work together and we find different ways to use different stress reducers that they can use that don't have the same side effects. So in my practice, I was using Suboxone. So Suboxone is sort of a substitute for heroin. So it gives you some of the same benefits, but hardly any of the same side effects, right? But in my model, it makes sense because I'm just looking, if it's a treatment, I'm looking for something that works okay, but doesn't have the same side effects. So in my office, I had 100 patients with heroin addictions that came to my office, and I treated them, and for most of them, I used Suboxone. And I got a 95% success rate. And here's why. Patients were attracted to come to my office. They wanted to come because they liked that idea that, I could be normal and I could have less stress. So they wanted to come to the office. And what I would do is prescribe them the Suboxone. And then during that time, I would say, here's how we're going to work on how your stress is. And whatever stress you have left over, we're going to find different stress reducers. And we're going to teach you new techniques. And then you're going to make a new neuronal track in your brain. And that's going to become automatic. And then as that worked, as that process was getting in place, then I would taper them off the Suboxone. Now, occasionally a patient would lapse. And I have to say that I differentiate lapses from relapses. Okay. So a lapse is when there's a short-term use of a relapse is when you're back full time. And my job then becomes, let me find the lapse before it becomes a relapse. And here's the problem. I can't get rid of the neuronal tract that's in their head. I don't have a little zapper that goes zap it out, right? So the risk of lapsing is always going to be there because that tract is always there. It never goes away. So all it takes is too much stress or too little inhibition, and the person's lapsed. But the key for the person now is they go, I didn't fail. I just had a setback. And now I just needed to figure out what happened there and get better. So one of the problems that people run into is deprivation. So deprivation is when you have something that you want that you can't get it. And that want can turn into a need very quickly. And so you need energy to stop. So I call it quit energy, right? So if your quit energy is more than your deprivation, then you're going to be successful. But energy isn't infinite. So if deprivation grows and keeps growing, now it needs more quit energy to stay stopped. But when deprivation goes above where your quit energy is, now you've lapsed. So when lapses occur under the disease model, people go, why did you make that choice? That was so stupid. You're going to give up everything. But in my model, what I say to them is like, you've been really successful for X amount of time. So what happened that you stopped inhibiting? And what they say to me always is that there was some kind of stress that increased in their life, and that's what led them to the problem. So my question then acknowledges their success and gives us a particular thing that we can work on. So in this model, empathy is really easy because here's the key. Anyone can end up in a loop. And anything we do to reduce our stress can turn into a loop. So my friend who's an orthopedic surgeon loves to play lacrosse. He's now had 8 surgeries on his shoulder, but he still wants to play. That's a stress reducer. And I'm like, dude, you're in a stress reducer loop. So I'm saying to you guys, like, I don't know how many people here drink coffee, but if you went to the coffee machine in the morning, stood in line, and got your coffee, and I said, you know what? You can't ever drink coffee ever again in your life. And if you do, you're going to lose everything. How many people are still going to drink that cup of coffee? So let's get back to Bill. So we met once a month. I gave him a Suboxone. He had an anxiety disorder, so I gave him a small dose of Xanax. We talked about new stress reducers, and he was sober for the 2 years that I met him. And I had the same success with my other patients, and so can everybody else, right? Oops. So what this model does in it gives people hope of being normal. It targets the real problem of stress, and it makes substitutes make sense. It targets inhibition. It reduces stigma because anyone or anything can become a loop. And now instead of calling people an addict or an ex-addict, you're just normal. And you got 1,000 tracks in your head, and you have one that isn't so good. But why would I identify you with that one track? It changes how we do research, and it keeps the problem in the medical model, and it gives us a common vocabulary. So I can talk about someone who has heroin addiction with the same words that I use to talk about someone who works too much. Different stress reducers, different side effects, same process. It rewards patients for their intelligence and resourcefulness while they're learning new tracks. It doesn't punish them for their choices. It rewards them for inhibiting. And lapsing is just a setback that can be overcome. So I want to give clinicians and family members a more positive message, and it makes them more empathetic. And patients are willing to come and get help. So I want families and clinicians and patients to have the same success that I had with Bill and others. If my experience proves to be reproducible, there's going to be more success in this world than that 20%. And I want to see stress reducer loop become the gold standard for treating patients for that problem that used to be called addiction. Thank you.